Hi everyone, my name is Lucia, a third-year medical student at the University of Toronto, and today I'll be presenting on my case report, a case of brain metastases masquerading as cognitive decline. To begin with an introduction, as you may already know, cognitive decline is a common presentation and a diagnostic challenge, one that must consider numerous differential diagnoses, including dementia. Given the profound impact of an individual's cognition on their functional status and quality of life, early recognition of reversible and treatable causes of cognitive decline is critical. As such, the objective of this case report is to describe the approach to a patient presenting with cognitive decline. Our case presentation involves an 86-year-old female who was admitted from a long-term care for a 2-week history of cognitive decline, hypoxia, and vomiting that began after receiving the second dose of the COVID vaccine. Her past medical history was significant for dementia, a right MCA stroke, and a benign left parietal neoplasm. On history, it was highlighted that at baseline, the patient could engage in full conversation, but over the past 2 weeks, the patient could only communicate with few words and became newly dependent with her ADLs. The physical exam was normal with no new findings. The patient's blood work, including TSH and vitamin B12 levels, were normal. A CT had demonstrated a new space-occupying lesion marked by the yellow arrow in Figure 1 in the left occipital lobe with vasogenic edema. Moving on to management, the patient was started on dexamethasone given the size of the lesion and edema. With this, her cognition significantly improved over days, allowing her to be involved in the decision-making of her care, including a transition to comfort care. Our discussion explores one's approach to cognitive decline. The first step in evaluating cognitive decline in the elderly involves differentiating between the 3Ds, dementia, depression, and delirium, as seen in Table 1. Once depression and delirium is ruled out, we can consider both reversible and irreversible causes of dementia, as seen in Table 2. A thorough history and physical exam is essential, as it can provide insight into the reversible causes of cognitive decline. For example, a history of cancer, as seen in our case, may heighten one's suspicion for a space-occupying lesion. In contrast, a patient presenting with Parkinsonian features may raise suspicion for etiologies such as Lewy body dementia. The recommended investigation for dementia by the American Academy of Neurology include basic blood work in addition to TSH and vitamin B12 levels. Further investigations that screen for more rare causes are reserved for those with risk factors or signs and symptoms suggestive of such specific etiologies. Finally, while neuroimaging is not routinely recommended, imaging with CT or MRI is indicated in patients with rapid neurologic deterioration or acute onset of cognitive impairment. In conclusion, our case report highlights the importance of maintaining a broad differential for patients presenting with cognitive decline, even in the face of known dementia. Furthermore, our case emphasizes the importance of a thorough history and physical exam in evaluating patients presenting with cognitive decline, as it can aid in the selection of relevant investigations and imaging. Thank you.